My name is Ty. My proudest financial accomplishment is retiring by the time I got to 40. When I left the job, I felt like I had been liberated. I get to this point where I tried a lot of I think it was a start. We're tied. University of Phoenix, prior eligible college grants. Plus, there's a scholarship just for transfer students. Transfer your eligible credits. Very important. All right. Good morning, everybody. I will email the files to Ms. Hushyar. Or if you can send me an email, I will send you the files. Sure. Sure, no problem. I will send you the files, but actually, send you can send me an email. That would be nicer. So I'm going to send you my email here. I'll send you a Gmail address so it's easier to work with in terms of FM. Yeah, yeah. Send me an email and I will reply to your email and send you the files. Yeah, that would be nice. All right. I think there are still a lot of students who are not present in the class. So could you please send a message, maybe if you have a WhatsApp group or some other means of communication to the rest of the classmates?
All right. In the name of God, today we are going to talk about immunodeficiencies. And immunodeficiencies are a group of disorders, actually two groups of disorders, in which immune system is unable to generate a sufficient immune response. So as you can see from the title, I have written primary immunodeficiencies and HIV/AIDS. So it's better to classify immunodeficiencies like this slide. We have two groups of immunodeficiencies: primary immunodeficiencies and secondary or acquired immunodeficiencies. And what is different between them is that the first one, the former, is usually due to genetic factors, but the second one is usually due to environmental factors. So if there is a genetic defect in one of the genes of the immune system, that would preclude us from generating sufficient levels of immune response, like antibody response or lymphocyte T cell response, or maybe response by phagocytes. Uh, the situation that we have is called primary immunodeficiency, and it's abbreviated as PID. But if the problem is from the environment, like some of the uh, problems that might originate from environments are things like HIV infection or some other infections that we will see later, which can lead to a decrease in the functioning, in the activity of the immune system and abnormal functioning of the immune system. That would be called secondary immunodeficiency. So this class, I will be talking mostly about primary immunodeficiencies, maybe 70% of the class. And the last 30% of the class, I'll be talking about one of the major reasons of secondary immunodeficiency, which is HIV/AIDS. So let's get started with primary immunodeficiencies. I'm going to use this model of the immune system again. This is a simplified representation of the structure of immune system. We have innate part of the immune system and adaptive part of the immune system. The innate part is composed of barriers, physical chemical barriers, and cells like phagocytes. And the adaptive part comprises B cells and T cells, which generate, the first one generates antibodies, and the second one generates another type of immune response, which is called cellular immune response. So if we use this simplified schematic as a representation of the structure of the immune system, we can sort of classify immunodeficiencies. Sometimes immunodeficiencies affect adaptive immune system, and sometimes they affect elements of the innate immune system. So if the adaptive immune system, both components of the adaptive immune system, meaning humoral and cellular components, are affected at the same time, we have something called combined immunodeficiency. So if there is a genetic mutation somewhere in the genome that influences either the production or the activation and functioning of B lymphocytes and T lymphocytes at the same time, concomitantly, we have something called combined immunodeficiency. If T cells are affected and B cells are not affected, we have the so-called pure T cell disorders. So in pure T cell disorders, only the T cell component of the adaptive immune system is affected. If B cells are influenced, but T cells are okay, we have the so-called pure B cell disorders. So we can have combined immunodeficiencies. Combined here means that both B cells and T cells are affected. Pure T cell disorders in which T cells are affected but B cells are fine, and pure B cell disorders in which B cells are not functioning normally, but T cells are functioning normally. So these three classes are basically depicting different types of immunodeficiency which affect the adaptive immune system. How about the innate immune system? Well, innate immune system, we have barriers and cells. We don't have a particular type of immune deficiency where barriers are affected. We have genetic mutations that affect the structure and the barrier function of the skin, but they are not usually classified as immunodeficiencies. They are usually considered dermatologic disorders. But cells that are phagocytes can be influenced by genetic mutations. So these are called phagocyte deficiencies. So if phagocytes are influenced, either their activation or their function, we have the so-called phagocyte deficiencies. And finally, we have a group of disorders which are caused by mutations in the genes that generate components of the complement or their regulatory factors, complement deficiencies. And when we say complement deficiency, well, complement in itself is considered part of the innate immune system. But as you know, like complement works in close association with antigens and antibodies, because the classical pathway for complement activation starts after an antigen antibody complex is formed. So it's kind of in between innate and adaptive. All right, so this is a relatively simple classification. We have 5 different classes or types. Combined pure T cell and pure B cell are related to the adaptive part of the immune system. Phagocyte deficiency and complement deficiency are related to innate and basically innate and adaptive parts of the immune system. So I'm going to start from one of the most severe forms of immunodeficiency, which is called combined immunodeficiency. And due to its severity, it's called severe combined. Oh, before doing that, in order to differentiate these different types of immunodeficiencies, I have made a table, and you can see a table like this in textbooks, that tries to differentiate between the types of deficiencies in terms of the infections that the person gets and in terms of the time of onset. You know, one of the major clinical manifestations of primary immunodeficiencies are infections. Well, sometimes the person who has been affected by primary immunodeficiency might also develop cancers, because the immune system is also responsible for generating anti-tumor responses. But well, the cancer or neoplastic manifestations of primary immunodeficiencies are less common compared to infections. So when we want to differentiate them, we can look at the patterns of infections. That would be helpful. So here I have 4 rows basically, because T cell deficiencies and combined deficiencies have similar features. So if the person has a T cell deficiency or combined immunodeficiency, which includes T cells, the pattern of the infection is basically opportunistic infections. Opportunistic infections are infections that usually do not affect normal people, or if they affect normal people, they generate a very limited type of infection. So opportunistic infections I will show you later, like thrush. So this is oral candidiasis, candida infection of the oral cavity. Normal people get it, but if they get it, it will be self-limiting and it will be localized. But if someone who has T cell problem, either T cell problem alone or T cell problem combined with B cell problem, they will have severe thrush infections. A lot of pneumonia with infections or infectious agents that usually do not affect normal people, and also some other infections like CNS infections. When do these infections start? Well, they can start right after birth, early infancy, like a couple of weeks after birth, these infections can start. So this is the way that T cell deficiencies, either pure T cell deficiencies or combined deficiencies, manifest themselves. For B cell deficiencies, the pattern of infections are slightly different. And these infections are sinopulmonary and GI infections mostly. So respiratory system and gastrointestinal system, as well as skin infections. And they start after 3 to 4 months of age. So unlike immunodeficiencies where T cells are affected, B cell deficiencies start showing up later. And what is the reason for this? Well, the reason is that when we are born, we have a relatively high level of maternal antibodies in our plasma, because maternal antibodies, especially IgG, they can get through the placenta, they can traverse placenta, and when we are born, we have a relatively high level of maternal antibodies. So those maternal antibodies are able to protect us against infections. But those maternal antibodies, after 3 to 4 months, their levels decrease. So we get the person, if he or she has a problem with his own B cells or her own B cells, will be susceptible to infections. The next group are phagocyte deficiencies, in problems with the activation or function of phagocytes like neutrophils. And in these cases, we will again have infections, but infections that are more common in phagocyte deficiencies are the so-called deep tissue infections. And they start before the age of 5. It varies based on the exact problem or exact genetic mutation, but it's usually 2, 3, 4 years of age. So, in order to sort of distinguish between the two later groups of infections, we can call these superficial infections. That's one way to remember them. So we have superficial infections like at the surface of the body. So the surface is the surface of the skin, the surface or epithelial layer of the sinuses, epithelial layers of the bronchi or lungs, epithelial layer covering the gastrointestinal tract. So that is superficial infection. But in contrast to B cell deficiencies, where epithelial cells of the sinuses or respiratory gastrointestinal tract get infected, in phagocyte deficiencies, you have deep infections. So deep infection like osteomyelitis, infection inside the bones, like pyogenic arthritis, infection inside the joints, or abscesses. Abscesses are collections of pus inside the tissues. So we can call these superficial infections versus deep infections. And usually superficial infections occur in B cell deficiencies, but deep infections are more common in phagocyte deficiencies. And finally, complement deficiencies. Well, we will see that complement deficiencies, sometimes they are associated with autoimmune disorders, and that's sort of counterintuitive because, well, it's an immunodeficiency. If it's an immunodeficiency, how come it can generate autoimmune problems? We will see the reason for that later. But they can also be associated with infections. And here, because complement has a very important role in defense against bacteria which have capsules, encapsulated bacteria, it's more common to get those kinds of infections like pneumococci. And depending on the exact mutation that you have in the complement system, the time of the onset would be variable. So this table is going to be very helpful to differentiate between these different types of immunodeficiencies when the patient starts having clinical manifestations. T cell and combined opportunistic infections very early after birth. B cell deficiencies, superficial infections, 3 to 4 months of age, because we have some antibodies. Phagocyte deficiencies are associated with deep tissue infections, usually when the person is 2, 3, 4, 5 years old. And complement deficiencies are associated with autoimmune problems as well as infections with encapsulated organisms. So let me start with combined immunodeficiency. And one of the severe forms of combined immunodeficiency is called severe combined immunodeficiency, that we will see about it later. So you know that we have B cells and T cells in our adaptive immune system, and B cells and T cells have cell surface receptors. So the cell surface receptors of B cells are basically membrane-bound antibodies, and the cell surface receptors of T cells, these are called TCRs. This schematic shows the stages of development of B cells and T cells. B cells develop in bone marrow and T cells develop in thymus. So we have a stage named pro-B cell, and then we have pre-B cell, immature B cell, and mature B cell. And likewise, we have pro-T cell, pre-T cell, immature T cell, and mature T cell. We have actually one extra step sometimes in here, which is called double positive T cells, which are T cells which have CD4 and CD8 at the same time, but I have not included that here. So in these stages, where pro-B cells are converted to pre-B cells and pre-B cells to immature B cells, and likewise for T cells, we have an important genetic phenomenon taking place in the genome of the cells, and that is called recombination, genetic recombination. And that genetic recombination is necessary for generating diverse sets of antibodies and T cell receptors. And the genes that are involved in genetic recombination are called recombination activation genes, number 1 and 2. So one of the reasons for combined B cell and T cell deficiency is when the person has a mutation in the RAG enzymes. So if the RAG enzymes are not functioning properly, development of the B cells and T cells would be affected, and then the person will have combined immunodeficiency. So that's one of the genetic mutations that can lead to severe combined immunodeficiency. But that is not the only reason. So if you recall from yesterday, we were talking about T cell activation. So we had this antigen presenting cell in here. It was showing antigens to T cells. Sometimes if we had interleukin 12, T helper 1s would develop. If we had some other cytokines, we would be getting T helper 3, some other situation, lack of interleukin 12 and presence of tiny amounts of interleukin 4, we would be getting T helper 2, and finally T helper 17. All of these cells, in order to get activated and proliferate, they require the cytokine named interleukin 2. So regardless of whether it wants to become a T helper 1 or T helper 2 or 17 or other phenotype, it needs to proliferate first. And for proliferation, you require interleukin 2. So interleukin 2, when it's produced, it binds to the receptors of interleukin 2 at the surface of the same T cell. So it's produced in an autocrine fashion. And for that reason, one of the problems that can influence T cell activation is mutation in IL-2 receptor. So if someone has a mutation in IL-2 receptor, his or her T cells will not be able to proliferate, and we would be having T cell deficiency. Well, it seems that mutation in T cell in IL-2 receptor would lead to pure T cell deficiency. But in reality, we will have combined immunodeficiency. Why? Because B cells are also heavily dependent on T cell activation in order to perform their functions. If you recall from yesterday, and the class that we had about immunology of infectious diseases, I mentioned that B cells, when they are alone, when they do not receive any help from T cells, they are only able to produce IgM. But for production of IgG, IgA, and IgG, which are quite necessary for a lot of the functions of the humoral immune system, for the proper functioning of the immune system, we require help from T cells. So if T cells cannot get activated properly, B cells will be influenced as well. And for that reason, IL-2 receptor deficiency is one of the most common reasons behind combined immunodeficiency. It's a T cell problem in origin, but it influences B cell activation as well. Another thing that might influence T cells and their proliferation is the lack of dNTPs. You know, when a cell enters mitosis, new DNA molecules would be synthesized using enzyme DNA polymerase. So DNA polymerase, in order to generate a new DNA strand, would require building blocks. And the building blocks of DNA are dNTPs, deoxynucleotide triphosphates. So deoxynucleotide triphosphates are synthesized inside our body, but sometimes the enzymes for generating dNTPs are mutated. The genes for those enzymes are mutated, and the enzymes are not functioning properly. So that would lead to a problem in T cell proliferation as well as B cell proliferation. And that is another reason behind combined immunodeficiency. And finally, the molecule in here, the MHC2 molecule, is very essential, is quite essential for T cell activation. So if there is a mutation in the genes encoding either alpha or beta chains of MHC class 2, again, we would be having insufficient T cell activation, and as a consequence, insufficient B cell activation. So all these three reasons can underlie severe combined immunodeficiency. So we have different reasons: mutations in RAG genes, mutations in IL-2 receptor, mutations in the enzyme named adenosine deaminase, which is required for dNTP synthesis, and mutations in MHC molecules that would lead to the so-called Bayer lymphocyte syndrome. Bayer here means that the lymphocytes are lacking MHC molecules. And while lymphocytes in here, because well, B lymphocytes also express MHC class 2, and well, at the same time, antigen presenting cells as well. So it would be more appropriate to call it bare maybe leukocyte syndrome instead of lymphocyte syndrome. So these are four groups of mutations or genetic reasons that underlie severe combined immunodeficiency. And this one is the most common form. By the way, we abbreviate it as SCID, severe combined immunodeficiency. Lack of IL-2 receptor or mutations in IL-2 receptor genes is the most common genetic reason for a SCID, severe combined immunodeficiency. So that could be a good point to learn, especially for the exam. And lack of adenosine deaminase, which is involved in synthesis of DNTP, is the second common form of severe combined immunodeficiency. So what do we see in SCID patients or severe combined immunodeficiency patients in their blood? If we test it, we will see either lack of T cells or very, very low numbers of T cells, either lack of B cells or very low numbers of B cells. Mitogens are things that can make T cells proliferate. So if we take some of those, basically the blood cells, the leukocytes, and add mitogen, we don't see any response because T cells are not there or their numbers are very low, and that low numbers cannot be activated. We see what is called hypogammaglobulinemia. Hypogamma means we don't have sufficient levels of gamma globulins. Gamma globulins are basically antibodies. Hypogammaglobulinemia. So the levels of antibodies are very low. And if the person gets immunized with a vaccine, the antibody response would be minimal, or the antibody response would be absent. So low or absent T cells, low or absent B cells, lack of response to mitogens, that is due to the absence of T cells, lack of sufficient levels of gamma globulins, which is due to low levels of B cells or B cell activation. And finally, if you immunize the person, you don't see a good antibody response. So as I mentioned, combined immunodeficiency or SCID usually starts with severe infections right after, like this example of a newborn that has progressive varicella or chickenpox infection. How can we treat these patients? Well, the only reliable treatment is to give them a bone marrow transplant. So getting stem cells, hematopoietic stem cells from a normal person, and injecting the patients with those stem cells so that those stem cells can enter the bone marrow and repopulate the bone marrow and start generating normal B cells and normal T cells. There are some research trying to perform gene therapy, and there are a couple of examples of successful gene therapies for adenosine deaminase deficiency. So that's another option. But if you don't have a suitable donor for bone marrow transplant and you don't have a suitable gene therapy option, the only way to keep these kids alive is to keep them in a sterile environment, in a completely sterile environment. Because if they live in a normal environment, they will be exposed to a variety of pathogens, viruses, bacteria, fungi, and they don't have B cells, they don't have T cells, and they are completely susceptible to severe infections, and well, they cannot survive. So here I want to tell you the story of David Vetter. David Vetter was a SCID boy who was born like in 1971, like 50 years ago, more than 50 years ago. And when he was born, he was diagnosed with a SCID. And basically, he did not have a suitable BM donor. So his parents decided to keep him in a sterile environment for as long as it's necessary, and while waiting for a suitable bone marrow donor to perform bone marrow transplantation. So he was born in 1971 and spent all of his life in a sterile bubble. So you see this plastic covered environment. This is where David Vetter lived basically all of his life. And everything inside had to be sterilized. Water that he was consuming had to be boiled. Foods had to be sterilized. Everything inside that bubble had to be basically autoclaved. Air had to be filtered, as I mentioned, and he had to live inside this bubble. And you can imagine how difficult it is. And in the media, he was named Bubble Boy. And even you see these holes in here, these are the so-called glove compartments. So if you want to change the clothes of the kid, you cannot take him out to change the clothes. First, the clothes had to be autoclaved and then put inside using a little opening that was being opened and then closed immediately. And then you would be putting your hands in the glove compartments, catching those clothes, and then changing the clothes of the kid, and then bringing the clothes outside to be sterilized again. Or even if he wanted to play with something outside the bubble, he had to put his hands in the glove compartment, bringing his hands out and maybe playing with something. So you can imagine how difficult it could be to be raised in such a limited environment. And when he was, I think, 8 or 9 years old, because he was kind of famous in American media and many people knew him, NASA, like the space agency of the United States, made him a suit like the suits that they make for astronauts that is completely uh, isolated from the outside environment. And he could wear this suit and come out. So the air that was going inside the suit had to be sterilized, and inside the suit was completely sterilized. And I think at the age of 8 or 9, he could come out of that bubble for the first time. So when he was, I think, 13 years old, his parents decided to give him a bone marrow transplant from a mismatched donor because they realized that the situation cannot be continued anymore. Unfortunately, the donor had a dormant EBV infection. EBV is a virus name which stands for Epstein-Barr virus, and today we can diagnose it by PCR, but PCR was not very common at the time in 1984. So the dormant EBV infection get activated inside the recipient, David's body, and he passed away due to a flare up of the EBV infection. So this is a sad ending to a story, a long, relatively the sad ending to a difficult life. But it also reminds us how grateful we should be for having a normal functioning immune system. If we had a skid, the only option for us was to live in a sterile environment. Like you wake up in the morning, you get a cab, you go to your class, you sit together with your classmates, you talk to them, you come out, go for lunch, maybe like going to beach and some other places, going to uh, shopping malls and going back home, no problem, because your immune system is protecting you against infectious agents that are present in the environment. But if you have mutations that would affect B cells and T cells, you wouldn't have any of those options. So you had to be living in a sterile environment or receive a bone marrow transplant later. All right, so that was a good example of combined immunodeficiencies, severe combined immunodeficiency, the classical example of combined immunodeficiencies. The second group, as I mentioned, are pure T cell disorders. Only T cells are affected, but B cells are fine. And in terms of opportunistic infections and start of those opportunistic infections right after birth, they're similar with combined immunodeficiencies, but because they have antibodies, the infections are much less severe. So we have a disease named Di-George syndrome, which is an example of pure T cell deficiency. So people who have Di-George syndrome have problem generating either TCR or another molecule which is involved in T cell activation, and it's due to a deletion on chromosome 22. They also have heart abnormalities, hypoparathyroidism, and well-thymic hypoplasia that would lead to T cell deficiency. So this is a kid with Di-George syndrome. They have particular facial features like a relatively big forehead, depressed sort of nasal bridge, and sometimes they have other facial features like the retracted lower jaw, which is called retrognatism, and sometimes they also have cleft lips or cleft palates. So these are representations of T cell, pure T cell deficiency. Sorry, these are representations of Di-George syndrome, which includes pure T cell deficiency as well. And they are also susceptible to opportunistic infections, but less commonly compared to people who have severe combined immunodeficiency. We also have pure B cell disorders. These are more common compared to pure T cell disorders. And I'm going to show you two diseases from the pure B cell disorder group, T cells are fine. The first two ones in this table, the first one is called common variable immunodeficiency. It's abbreviated as CVID, and the second one is called Bruton or X-linked A gamma globulinemia. We have other ones as well, but I'm going to teach you only the CVID and the Bruton. You can also read about the rest of them if you want. I have slides, but the slides are hidden in this PowerPoint file, but they're included in the PowerPoint file. So what is what is CVID? Don't mix it up with SCID. SCID is B cell T cell disorder, severe combined immunodeficiency. CVID is common variable immunodeficiency, and it's a B cell problem. And as you can see here, it's relatively common compared to other types of immunodeficiencies, and it has variable manifestations. And then we'll go to Bruton. So this is a B lymphocyte. And at the surface of the B lymphocyte, we have antibodies that are bound to the B lymphocyte. So if you have an antigen and this antigen binds to these antibodies, signals will be sent to the cell nucleus telling it that you need to get activated. And usually B cells proliferate first, they increase their numbers, and then they differentiate into the so-called plasma cells, and then they can produce antibodies. So antigen binding to the antibodies will initiate B cell mitosis. So you will have a lot of B cells, and then these B cells will start secreting the antibodies. So for this process to happen, for this process of B cell activation to happen, if I make a sort of a bigger version of this, you require the antibody molecule. But in addition to antibody molecule, you require some other molecules as well. And these are called co-receptors. Receptors that are kind of helping the main receptor, like molecules like CD19, CD20, CD81, and this molecule, which some people read it TACHI. So if you have mutations in any of these, then the process of B cell activation will be affected. So B cells exist, they look normal, but when they get exposed to the antigen, they don't respond well. And that would lead to what is called common variable immunodeficiency. So common variable immunodeficiency results from mutations in the genes encoding B cell co-receptors. So it's a problem of B cell activation. What are the features that we see in here? We had this expression hypogamma or hypogammaglobulinemia. So here we add a prefix pan. What does pan mean? It means everything. And pan-hypogamma, it means that we are deficient in IgM as well as IgG as well as IgA. So IgM, G, and A are three classes of immunoglobulins which are present in plasma at high levels. We also have IgE, but IgE's levels are very, very low. And IgD is extremely low as well. IgD is usually not secreted, but for some reasons, we have extremely low levels of IgD in plasma. So when we say panhypogammaglobulinemia, we mean that three major classes, A, G, and M, are either low or they're absent. Well, hypo means they're lower than normal. So, and this is what happens in CVID, because B cells cannot get activated. You don't have IgM, you don't have IgG, and you don't have IgA. And at the same time, you have some other manifestations. You have lymphadenopathy, lymph nodes get enlarged, and you have splenomegaly. So why this happens? Well, it seems that when B cells are not functioning properly, T cells try to make up for the deficiency in B cell activity, and they proliferate more than what they should, and that would lead to enlargement of lymph nodes and enlargement of the spleen. So B cells are not there. B cells are there, but they don't get activated. They don't work sufficiently. So T cells try to compensate for the lack in B cell functioning, and then you have enlargement of lymph nodes and spleens. So panhypogammaglobulinemia, it means that in a normal person, before you inject them with any antigens. How if we vaccinate the people? What if we give them some antigen to activate their B cells? Well, again, we would be seeing a very poor antibody response, either to vaccines which are made from polysaccharides, bacterial polysaccharides like pneumococci, pneumococci or protein vaccines. So the baseline levels are low and the response after vaccination is low either. The interesting thing is that if you look at T lymphocytes or B lymphocytes in blood, you don't see a clear abnormality. T cells are completely fine. Well, this is a pure B cell problem, so we don't expect to see problems in T cells. But B cells also look normal. So the number of B cells are normal. And if you look at them in terms of their morphology, they look okay. Because this is not a problem of B cell production. CVID is not a problem of B cell production. B cells are produced okay, but they cannot get activated. And that is important. And that's important in differentiating it with the next disease that I'm going to tell you about, which is Bruton's disease. In Bruton's disease, that we will see in later slides, B cell production has problems. Well, what kind of infections these people get? I showed you in the one of the first slides, superficial infections. Skin infections, GI tract infections, and respiratory infections. Infections of other places might occur, but they are much less common. So a person with CVID would show up with the skin infections, with the sinusitis in the upper respiratory tract, with bronchitis in the lower respiratory tract, with pneumonia, again in the lower respiratory tract, with GI tract infections. And one of the common GI tract infections is a parasitic infection with the so-called Giardia lamblia or Giardia duodenalis. So these are infections that these people get. So this is an example of infections that you see in a CVID case, and this is an infection which is associated with granuloma formation. So you will see later in pathology classes that we have something named granuloma, and granulomas are where when you have a lot of T cells accumulating at the site of the infection. As I mentioned in CVID, T cells try to compensate for B cell deficiency, so the lymph nodes get bigger, spleen gets bigger, and then when you have an infection, well, B cells cannot produce antibodies to protect, so T cells will go there to fight. And when you have too many T cells, too many antigen presenting cells, something called granuloma is formed, so granulomatous infection. This is a picture from endoscopy in a CVID patient, and you see the so-called these bumps that you're seeing in here. These are localized enlargement of lymphoid nodules, below the mucosa, intestinal mucosa. We have the so-called mucosa-associated lymphoid tissue, and this mucosa-associated lymphoid tissue, at some places, it has an organized structure. It's called organized mucosal associated lymphoid tissue, or OMALT, M-A-L-T, mucosa associated lymphoid tissue. It's called OMALT. And in some places, it's diffuse. It's spread all around, and it's called diffuse malt. So in OMALT and DMALT, we have an increase in the proliferation of T lymphocytes, and you see these kind of nodules there. And well, this is not something that you can see in regular physical examination. The patient has to undergo endoscopy. And patients who have recurrent gastrointestinal infections, usually they undergo endoscopy, and this is something that the gastrointestinal or gastroenterologist might show in his or her report, and you will see it in the report from the patient. Again, you see the nodular pattern in jejunal mucosa, and this is a patient that has severe Giardia infection. This is another example of infections in people with CVID. I mentioned infections in the lung. Well, they get bronchitis, they get pneumonia, and they get bronchopneumonia, in which both bronchi and alveoli are infected. And if a person undergoes recurrent bronchitis or recurrent bronchopneumonia, after some time something happens, then bronchiectasis. It means dilation of bronchi, but it's not really dilation of bronchi in the sense that bronchi smooth muscles are not contracting well. It's due to basically the destruction of the walls between bronchi. So it's bronchiectasis. We have bronchodilation, we have bronchiectasis. Bronchodilation is like when you use particular drugs, like in asthmatic patients, they use beta agonists so that their bronchi are dilated and they can breathe better. So there is no destruction of tissue there. But in bronchiectasis, it's abnormal or destructive dilation or destructive, basically joining of different bronchi, and you see bronchi associated with each other. So you have these huge things in here, which denote the destruction of bronchial walls due to recurrent infections. So we have skin infections, pulmonary infections, and gastrointestinal infections. CNS infections or joint infections might happen, but they are much less common in CVID. So opposed to CVID, as opposed to CVID, we have another B cell problem, which is an X-linked disorder. So the gene responsible for it is located on chromosome X, and for that reason, most of the patients that are affected are males, they're boys. And after the physician that described it for the first time, it's also called Bruton syndrome, but it's easier to call it XLA, X-linked agammaglobulinemia. And unlike CVID, here we have a problem in B cell production. In CVID, B cell production was okay, B cell activation had problems. In here, B cell production has a problem due to mutations which influence B cell development either at the pro-B to pre-B stage or pre-B to immature B stage. What is the problem? We have an enzyme, it's a tyrosine kinase named BTK. B comes from the name of Dr. Bruton, and TK is tyrosine kinase. It's a kinase that adds phosphate to tyrosines, and this BTK is essential in normal B cell development. So people with XLA have mutations in their BTK, and for that reason, when you look at their blood, they don't have B cells. And this is different from CVID. In CVID, B cells are there, but they do not get activated. But in XLA, they don't have B cells, and they lack different classes of antibodies. So in CVID, we could have low levels of antibodies. It was called pan-hypogamma. Hypo means lower levels. But in XLA, as you're seeing in here, the letter A in here, it's A gamma globulinemia. They're almost absent. You don't see anything. Because B cells are not there. Well, when B cells are not there, you don't see anything. Lack of all classes. And this is called pan-A gamma globulinemia. Pan-A gamma globulinemia. What kind of infections? Infections are similar: skin infections, respiratory infections, and to some extent, gastrointestinal infections. So what is the treatment for these disorders? Well, for CVID, if it's called common variable, so variable in terms of its severity. If it's not very severe, you try to prevent infections, especially pulmonary infections, by keeping the person away from infected people, or also sometimes vaccination might help a little bit because they have a tiny bit of antibody response. And if they get infected, you would give them antibiotics. But in XLA, that's not an option because there are no B cells. Even low levels of antibodies don't exist. So you have to give them antibodies. So how do you give them antibodies? You have to give them a mixture of antibodies. You isolate immunoglobulins from normal people's sera and inject them intravenously. It's called IVIG, intravenous immunoglobulin, every 3 to 4 weeks, because antibodies have a half-life of almost 3 weeks for IgG. So you have to repeat the injections almost every month. You can also give IVIG to CVID cases which are severe. So if CVID is not very severe, try to prevent infection, try to treat infections when they happen. But if they are severe, you would give them IVIG. But for Bruton, the only choice that you have is basically monthly IVIG treatment. So gene therapies are also another option, and bone marrow transplants are another option for XLA people. So this is an example of a skin infection. In Bruton hypogammaglobulinemia, well, it's more accurate to say agammaglobulinemia in a 2-year-old body, two-year-old boy. This is again, well, in this chest X-ray, you might not see it very well, but this region in here shows what is called bronchiectasis due to recurrent pneumonia. Another example of infections that happen in XLA people, and some other infections that might occur in the gastrointestinal tract. All right, so let's move on to phagocyte deficiencies. So in phagocyte deficiencies, this part is influenced, and these are considered problems of the innate immune system. And as I mentioned, these infections are associated with deep tissue. These syndromes are associated with deep tissue infections. So we have several examples of them. I want to tell you about the first two ones: chronic granulomatous disease, or CGD, and a syndrome named Chedyak-Higashi syndrome, which is abbreviated as CHS. We have some other cases as well, but I won't discuss them, only the first two ones: CGD and Chedyak-Higashi syndrome. So if you recall from yesterday, we mentioned that in defense against some bacteria, especially bacteria that are hard to kill, we need to generate reactive oxygen species, So when the bacterium is phagocytosed, its antigens are presented to T cells. T cells will get activated, they produce interferon gamma, and interferon gamma would tell the macrophage or the phagocyte to start producing superoxide, and then superoxide will lead to generation of other types of reactive oxygen species like hydrogen peroxide and hypochlorite. So this is very important in defense against bacteria, which cannot be killed by mere phagolysosome formation. So this shows a phagocyte. This green thing that you're seeing in here is a phagocyte that has phagocytosed the bacterium. This is a bacterium, and this is a phagosome that is being closed off. So for superoxide to be produced, you need an enzymatic complex in the membrane of the phagosome. That enzymatic complex, all what it tries to do is put an extra electron on the oxygen molecule. And chemically, this is a very difficult thing to achieve, because oxygen molecules do not like an extra electron to be attached to them. So we have a relatively complex enzymatic structure in here that has multiple components, and it's called NADPH oxidase. It's called NADPH oxidase, or phagocyte oxidase. Some people call it fox, but not the fox, the animal, this kind of fox. So phagocyte oxidase. So phagocyte oxidase, or NADPH oxidase, equal to NADPH oxidase, is the enzyme which is responsible for generation of superoxide, superoxide, O2 minus, superoxide. So if you have mutations in any of the components of the phagocyte oxidase, the phagocytosis will be performed, but O2 will not be generated. And as a consequence, the rest of the reactive oxygen species will not be generated as well, because O2 will generate H2O2, and this will generate the so-called HCl, HClO, which is hypochlorite. And together, all of these things are called reactive oxygen species. So you perform phagocytosis, but you cannot kill. At least the bacteria which require ROS for the killing, you cannot kill them. And that would lead to something which is called chronic granulomatous disease, or CGD. And you see, like the skin infections in here, again, you have granuloma. So you hear this word granuloma a lot. We had granuloma formation somewhere here as well, like when we were talking about, I think, one of these diseases. We had enlargement of lymphoid tissues, and we had granuloma formation in some of the previous diseases that I showed you. I think it was this one. Well, this is again a granuloma formation. So why granuloma? Because when you don't have sufficient function from phagocytes, again, T cells will try to take over. And they will go to that region, and they will try to produce a lot of inflammatory cytokines in order to get rid of this stuff. And actually, one other reason is that T cells are responsible for producing interferon gamma, so that interferon gamma can stimulate the production of ROS. When ROS is not generated at sufficient levels, more and more T cells will go there to push the macrophages to produce ROS. So they will try to increase the level of interferon gamma production so that they can push macrophages to produce ROS. And that would lead to the formation of what is called a granuloma. And granulomas themselves can be destructive. So this is another example of a CGD kit. he has skin infections inside the tissue, and again, skin granuloma formation, which you cannot see it very well in here, but if you do pathological examination, they will be obvious. And sometimes these granulomas can be very destructive. So this is a CGD patient that has had an infection in the nasal area, but due to granuloma formation, the entire nose has been basically destroyed, and this is called rhinoscleroma, which is a manifestation of CGD. So CGD is associated with abnormal production of reactive oxygen species. Phagocytosis is okay, but the killing is not okay. So the next disease, which has been named after two Japanese scientists, it's called CHS. So the previous one was CGD. This is CHS, Chedyok and Higashi syndrome. This is an autosomal recessive disorder. And unlike the previous ones, this is a disorder that also influences other systems. Why? Because it's a problem of vesicle transport. Problem of vesicle transport. You know, I got this, I generated this using Google Gemini AI image generator. So I described the Chedyok-Higashi syndrome, and I told it that, well, this is like the problems in the railroads inside the cells. You know, in different countries, in order to perform the transportation, you have trains and you have railroads. So these railroads carry, or trains carry, different cargoes at the surface of these railroads from between different cities. So if the railroads are not okay, if the railroads have problems, then the movement of the trains and the movement of cargoes will have problems. So we have a railroad inside the cells. We have a railroad inside the cells that connects different parts of the cell. Like this is the nucleus. It has some railroads carrying the stuff inside it, carrying the stuff outside it. This is the mitochondria, which is the power station of the cell. It has some railroads carrying the stuff inside it and outside it. And even more importantly, we have a lot of vesicles, especially lysosomes, that have to go and basically perform cleavage on proteins and different macromolecules which are inside cells. So there are railroads carrying lysosomes around. So if these railroads are broken, then we will have a lot of issues in vesicle transport and in cargo transport. So this is what happens in Chedyok-Higashi syndrome. The railroads that we have are made from microtubules. So this is a staining of a cell in which microtubules have been stained green, and you see there is a network of microtubules inside the cells, and these blue ones, these are vesicles that are transported at the surface of microtubules. So it's something like this. This is the microtubule, this is like a railroad, and then we have proteins like trains that put a cargo at their back and they move them. These proteins are named kinesins, and the cargo could be anything. It could be a vesicle, it could be a tiny organelle that is being shaped, it could be different things, but they are mostly vesicles. So they are transported across this railroad to different parts of the cell. So if there is a problem with these kinesin molecules or molecules that are involved in vesicle transport, then we would have a difficult situation inside the cell. So the cargoes will not be transported, and a lot of problems would occur. What kind of problems? Well, one of the problems that would occur is that the person would be having hypopigmentation or albinism. Why? Because for the skin coloration to happen naturally, we have vesicles full of melanin. They are called melanosomes. They are generated in melanocytes, but they have to move towards keratinocytes in order to generate normal skin coloration. So that would be problematic if you have problem in vesicle transport. Then we have immunodeficiency, because transport of vesicles are very important for the normal functioning of phagocytes. When something is phagocytosed, phagosomes and lysosomes have to merge, so they are not like floating around in the cytoplasm. They are moving alongside these railroads or microtubules to merge. So if there is a railroad problem, you would be having abnormality in performing phagocytosis. There would be neurological abnormalities because vesicles at the synaptic ends that carry neurotransmitters have to use these railroads in order to move. And they would also even be bleeding problems because platelets have vesicles inside them that are involved in coagulation processes, and they could be affected as well. So Chebyak-Higashi is a railroad problem, well, microtubule transport problem, and different things can happen. So one of them is albinism, because, as I mentioned, melanosomes cannot be transported to keratinocytes. Well, this is complete albinism, but in most cases, it's not complete albinism. It's sort of a reduction, it's a hypopigmentation, and the so-called silvery hair syndrome. So the hairs that you're seeing in here, because the color of the hair is also due to melanosomes, that when the hair follicle is making the hair, those melanosomes are injected sort of into the hair. So it's not complete albinism like what you're seeing in here. Most of the times it's like a silvery hair syndrome, which is an example of hypopigmentation. And at the same time, actually, you see some skin infection in here. If you look at the cells under the microscope, you see giant granules in neutrophils. So a normal neutrophil, the granules are quite small, but in here you see big ones, big ones. Why? Because it's like broken railroad, different trains bump into each other and sometimes merge into each other, and they make bigger entities. So the giant granules that are present in neutrophils are also a result of the vesicle transport problem. And at the same time, these neutrophils are unable to perform phagolysosome formation. You recall from yesterday that merging of phagosomes and lysosomes is a very essential early step in defense. So that process of phagolysosome formation is dependent on normal vesicle transport. If the normal vesicle transport doesn't happen, the phagolysosome formation would be problematic, would have problems, and then the killing process would be affected as well. So that is Chebyak-Higashi syndrome. And finally, complement deficiencies. Well, complement deficiencies, we have so many of them, but I want to summarize it in one single slide because we need another 10 minutes at least to talk about HIV. So this is the complement pathway. If you recall from previous classes, these are proteases in plasma or serum that can be activated in order to mount a defense. And the way that they generate defense is that when an antigen and antibody bond to each other, the C1 component gets activated, and it leads to the activation of C4 and C2, and finally to activation of C3. So this is called the classical pathway of complement, or the classical activation pathway, starting from C1. Sometimes antibodies and antigens are not there. So there are molecules at the surface of particular bacteria that can activate C3b directly together with a component named B component and P component, and this is called alternative pathway. So either classical activation or pathway alternative activation would lead to activation of C3, and C3 would lead to activation of C3 activation would lead to activation of C5, 6, 7, 8, and 9. That together, all these things generate something that is called a membrane attack complex. It's a hole at the surface of the bacterium or the target cell that will lead to osmotic lysis. So if C3 is deficient, if these late components are deficient, like C5, 6, all the way to 9, we have the so-called recurrent infections with encapsulated bacteria, including Neisseria infections, because the formation of membrane attack complex is very important for defense against Neisseria infections like gonococci and meningococci. So late components deficiency are associated with recurrent infections, especially with Neisseria. What about C3 itself? C3 has a central position in the complement pathway. Again, if you have C3 problem, you will have infections which are called pyogenic infections. Again, these are bacterial infections which are associated with production of pus. It could be Neisseria infection or streptococcal infection or staphylococci infection. So these two parts, late components and C3, are associated with infections. The classical pathway, if you have deficiency in classical pathway, the representations are slightly different. Here, instead of having infections, we usually have autoimmune problems. And this is sort of counterintuitive. We don't expect it. We don't expect autoimmunities to be a representation of immunodeficiencies. So why this happens? Because one of the functions of the classical path of complement is to clear antigen antibody complexes. You recall yesterday we were talking about hypersensitivity type 3. And in hypersensitivity type 3, antigen antibody complexes would form, but they cannot be cleared out because we have problems in the clearance, or because we have too many antigen antibody complexes being formed. And then those antigen antibody complexes will go and get deposited in different tissues, like in kidneys, and that would lead to inflammation. Like in case of lupus, we had lupus nephritis. So these components of complement are essential in clearance of antigen antibody complexes. So they have to get activated, and C3 generates a component named C3b, which performs opsonization. So that opsonization would facilitate the phagocytosis of antigen antibody complexes by macrophages and monocytes. So if you have problem in here, those antigen antibody complexes will not be cleared, and they go and get deposited in different tissues, like in kidneys or skin, and they would lead to autoimmunity. Sometimes we also have infections in here. And finally, for the alternative pathway, again, we have infections which are called pyogenic. So pyogenic, it's as opposed to viral infections. Viral infections usually don't generate pus. Pus, P-U-S, is a collection of dead neutrophils, basically. They say pyogenic, it means pus, Pus, forming infections. And pyogenic infections, as I mentioned, is usually streptococcal infections, staphylococcal infections, infections with encapsulated bacteria, and things like that. All right, so in order to memorize it, everything leads to infection, basically, except classical pathway, whose major presentation is autoimmunity. All right, so we talked about primary immunodeficiencies. We'll be done in another 10 minutes. Primary immunodeficiencies, we talked about severe combined. Okay, so maybe I can ask you a question. In severe combined or a SCID, what kind of problem do we have? Do we have problem in T cells, B cells, or phagocytes? Can you type it for me here? In a SCID, severe combined immunodeficiency, which kind of cells are affected? T cell, B cell, phagocyte. We can type TBPH. That would be easy. TBPH. Okay, only one response. All right. So both T cells and B cells will be influenced. All right. How about Dye-George syndrome? In Dye-George syndrome, is it TB or phagocyte? TBPH? Is it T cells, B cells, or phagocytes? All right, in Dye-George, it's only T cells. In CBID, it's only B cells. In Bruton, it's only B cells. In CGD, we have problem with phagocytes. ROS would not be produced. CHS is Chet-Yakigashi, which is the problem with vesicle transport. And these are all due to genetic mutations. We have another group of immunodeficiencies, which are called secondary immunodeficiencies or acquired immunodeficiencies. And unlike PIDs or primary immunodeficiencies, secondary immunodeficiencies are due to environmental factors. They are not due to genetic mutations. Like aging, for example. Some very old people at old age, the activity of their immune system decreases, and it could be part of aging process. And it's an example of secondary immunodeficiency. If the person receives corticosteroids, so corticosteroids are used for treatment or control of inflammatory disorders. High doses of corticosteroids can lead to immunodeficiency. Another example is malnutrition. Insufficient level of carbohydrates and proteins, especially if it's prolonged malnutrition, would lead to secondary immunodeficiency. Some other chronic diseases might also lead to that. Viral infections, like CMV infection, for example, measles infection, for instance, they can lead to transient immunodeficiency. But perhaps the most important one in our times is HIV infection. And HIV is a virus that directly targets CD4 T cells. And well, we know how important CD4 T cells are in the functioning of the immune system. They are top officers of the immune system. So the story of HIV and AIDS started in 1981, more than 40 years ago, when a group of homosexual men and IV drug abusers were diagnosed with an atypical pneumonia. So they went to a clinic in New York, They had pneumonia. Well, they thought that this is probably a bacterial pneumonia. They started giving them antibiotics, but it didn't work. So when they took an X-ray, they could see these opacities in their lungs. But the surprise came when they looked at the sputum samples. So they looked at the sputum of these uh, patients, and they saw something that was very surprising. They saw a fungus. It was a fungal pneumonia. What was the fungus? It's a fungus named pneumocystis. It's a fungus named pneumocystis. So why was this surprising? Because pneumonia caused by pneumocystis had never been reported before in adult patients. The only cases of pneumocystis pneumonia uh, that were known at the time were in children who had primary immunodeficiency uh, that was affecting T cells. Children with T cell deficiencies, pneumocystis pneumonia had been seen in them. But in adult people, no. These were people, men in their 30s or 40s. They had lived normally for 3 to 4 decades without any infections. And all of a sudden, they're showing up with a pneumonia whose causative agent is a fungus that doesn't show up in adults, in normal adults. And by the way, I wanted to tell you about one particular term I forgot to tell you in the beginning of the class. So we have two terms, immunocompetent, immunocompetent, and immunocompromised. Immunocompetent is a normal person, an ordinary person whose immune system is competent, is working normally. Immunocompromised is a person whose immune system is not working normally, And immunocompromised is basically synonymous with immunodeficient, immunocompetent and immunocompromised. So pneumocystis pneumonia had never seen before 1981 in immunocompetent people, only in children with T cell deficiencies. And it was surprising that a group of adult men in their 30s or 40s were showing up. So they recognized that these people have become immunocompromised, and they probably have T cell problem. But this is not a T cell problem due to genetic reasons. This is not a T cell problem due to genetic reasons, because if it was due to genetic reasons, they would have shown it much, much earlier in their early childhood. So HIV was discovered as the causative agent for this problem that was later named AIDS, or acquired immunodeficiency syndrome. So HIV is a retrovirus. It has RNA molecules inside it. It has cell surface protein named GP120 that binds to the cell surface protein named CD4. So CD4, we know it for it's present at the surface of T helper cells, but CD4 is also present at the surface of monocytes and macrophages. So HIV can affect monocytes and macrophages. It injects its RNA inside the cell. It makes a cDNA, or a complementary DNA, from its RNA by an enzyme named reverse transcriptase. And for this reason, it's named a retrovirus, because normally in the cells, it's DNA that is transcribed to RNA. Here, RNA is converted to DNA in a process named reverse transcription, even opposite of transcription. And then this DNA that is made will get integrated into the genome of the cell. So it will go and insert itself inside our own cell's DNA, and then new RNAs will be generated, new proteins will be generated, and new HIV particles will be generated. So this is HIV's replication cycle. And this is what happens in macrophages. The same thing can happen in lymphocytes, and it's basically the same story. The only difference is that in lymphocytes, the core receptor is different. The secondary receptor, which is required for the infection, is different. In macrophages, it's a molecule named CCR5, and in lymphocytes, it's a molecule named CXCR4. There is also another difference. HIV doesn't kill macrophages or monocytes, but it kills CD4 T cells. So the infection for CD4 T cells is a lytic infection. It will lead to cell lysis. And it removes CD4 T cells from lymph nodes and from blood. So this shows the natural course of HIV infection. There are 3 phases in the HIV infection. The first phase is called primary infection. And in this schematic, we have these two lines. This shows the number of viral particles that you see. It goes up very fast in the beginning of the disease. And this shows the count of CD4 T cells, the count of the CD4 T cells. So in the beginning of the infection, HIV goes up very fast and it kills a lot of CD4 T cells. But then CD4s recover and HIV proliferation decreases. And this is probably due to the activity of CD8 cytotoxic cells that kills a lot of those CD4s quickly so that HIV cannot proliferate as fast as it wants. And this is called primary infection. The patient might be asymptomatic, or he or she might have very mild symptoms like a flu, influenza-like, some fever, and maybe some body pain, symptoms like influenza. After that, the patient feels okay. Patient feels healthy. It's called the latent phase. In the latent phase, the virus goes inside the lymphoid tissues where the majority of CD4 T cells are there, and it kills them slowly. So it proliferates slowly and kills them slowly, and it empties the reservoir of T cells, which are basically secondary lymphoid tissues. So if you look at the blood, it seems that CD4s are okay. You don't have a severe decrease in the number of CD4s. But in reality, CD4s are being depleted from the lymphoid tissues. So this is called the lymphocyte latent phase, low levels of virus replication in lymphoid tissues. Lymphocytes are dying gradually. And this period might take between 1 to 15 years. So in the 80s, when antiretroviral therapies were not available, this could be as short as 1 year. And then after that, the number of CD4 T cells would drop significantly. But today, with antiretroviral treatments, it could be like 30 years, 40 years. Like the patient can be kept in the latent phase for a very long time. HIV would still be present and the patient might still be contagious for other people. But the viral production is kept at very low levels using antiviral drugs. And finally, if the killing continues in peripheral lymphoid tissues, we will reach a stage where the number of CD4 T cells in peripheral blood will decrease. If the number of CD4 T cells decreases below 200 per cubic millimeter, then we have a situation named AIDS. So up to now, up to this point, the first stage and second stage, the person is HIV positive, but we don't have AIDS, we don't have the immunodeficiency because, well, we still have sufficient number of CD4 T cells. But in here, we have the full manifestations of AIDS, which are usually severe infections, and then it might lead to death. So these are the three stages of infection. So what are infections that happen in here? If you recall from previous slides, I showed you that when we have T cell problem, the type of infections that we have are opportunistic infections. Opportunistic infections are infections that do not happen in immunocompetent people. So now I'm going to use the terms. They don't happen in immunocompetent people, or if they happen in immunocompetent people, normal people, they are very localized. One of them is candidiasis, oral thrush. So normal people usually don't get candida infection, or if they get it, it's very limited and it goes away after a while. But severe candida infection, like what you're seeing in here, it's affected the ovula, it's affected the soft palate and part of the hard palate. This is what is seen in people who have T cell problem. And this is another case of severe candidiasis. So this is an example of infections that you see in AIDS patients. Some other infections that usually don't see in immunocompetent people, like toxoplasma. So toxoplasma is a eukaryotic organism that is transmitted to humans by felines, by cats. So if you have a toxo infection, it's usually kept inactive. But some in immunodeficient people that have T cell problems, you can have severe toxoplasmosis, like the cysts that you're seeing here in the cerebellum, or this big lesion in here that you're seeing. It's a relatively massive lesion, so-called space occupying lesion, as neurologists would call it. It's due to activation of a latent toxoplasma infection. Some other infections that you're seeing in here. So you know herpes infection. Well, immunocompetent people might get herpes infection. We might have experienced it ourselves. So especially in stressful conditions, when the person is stressed, maybe before exams. Sometimes you might have a tiny herpes infection on the lips, but it will go away. But if the person has T-cell problems, including in people with AIDS, you can have severe herpetic infections, as you're seeing in this kid. Even the nasal region has been affected. HPV infections. So HPV can be responsible for warts. So, and particular types of HPV can also be responsible for cervical carcinoma. But this is, in this case, this is an HPV that causes warts. So warts can happen in immunocompetent people, but they are very, very limited. But warts that you're seeing in here, multiple warts due to HPV infection. Again, this could be a manifestation of a T cell problem secondary to HIV infection, and other infections as well. Like we have EBV infections, Epstein-Barr virus. In immunocompetent people, EBV infection is usually self-limited. It might cause a disease named infectious mononucleosis, which will go away in itself. But sometimes we have severe infections like this EBV infection of the tongue. So in addition to infections, which can be viral infections or fungal infections or bacterial infections, we also have cancers in AIDS patients. So this is an example of a cancer in AIDS patients. It's called Kaposi sarcoma. And this is an infection, sorry, this is a cancer which is associated with a viral infection. It's associated with what is called Kaposi sarcoma herpes virus. And again, the occurrence of this cancer is because of the lack of the activity of CD4 T cells. It can have oral manifestations like what you're seeing in here, and other type of cancers that you usually do not see in immunocompetent people, like brain lymphoma. So a collection of infections and cancers is what you see in HIV people have developed into AIDS. So what you need to know about diagnosis of HIV, I think this is my last slide. Sometimes you look for antibodies against the virus, sometimes you look for the antigens, and sometimes you look for nucleic acids. So viruses, unlike bacteria, you cannot easily see them under a microscope. Like if a person has a bacterial infection, like bacterial infection of the throat, or even bacterial infection in blood, you can take a sample of the throat or basically or blood sample and put it on a slide and stain it with bacterial staining procedures like gram stain, and you look at it under, and you can culture or you can culture the sample to increase the number of bacteria, and then you stain them and you look at them under a regular light microscope. But for viruses like HIV, that is very difficult. You cannot see them under light microscope because they're too tiny. You have to use electron microscopy, which is a relatively difficult process. So you don't look for the virus particles by looking at the samples that you get from HIV positive or potentially HIV positive people. You look for antibodies that our bodies have generated. And the antibodies that we are looking for are antibodies against that cell surface or viral surface protein named GP120. So using a method named ELISA and another method named Western blots, we look for antibody responses. So that's one thing to keep in mind. Sometimes we look for antigens of the virus. So instead of looking for antibodies, or together with looking for antibodies, we also look for viral antigens, again, with a method named ELISA. And sometimes in order to have the highest level of specificity, we perform PCR. And I'm just going to show you the difference between these things. So HIV PCR versus antibody versus P24. If you want to see the difference between them, this is how they would look like. Let me see if I can bring up another one. I don't have it in my slides. So yeah, that would be good. Let me see. So the first thing that goes up, or the first test that gets positive, is the PCR test. The second test is P20 vision. Well, you don't see it very well in here. I don't see if, yeah, okay, this is not HIV though. So, okay, well, we don't need the figure. I have it in one of my other presentations. If I can pull it up, give me a second. Give me a second. My class, clinical immunology 2 and infectious diseases. Okay, so this is a class that we will have later. This is the one that I was going to show you. This is for clinical immunology. There we'll be talking about HIV again. And okay, yeah, this one. So when you perform testing for HIV, the first thing that goes up is HIV RNA, which is detectable by PCR, then HIV antigen, P24, then anti HIV IgM, and finally anti HIV IgG. And there is a period, like this is the beginning of the infection, day zero, if the person has had a suspicious sexual contact or needle stick, so you assume that that has been the day zero. So if you test the person for the antibody like a couple of weeks later, the antibody might still be negative because antibodies would require some time to be generated. Even the antigen, in order to reach sufficient levels so that we can detect it by ELISA, it needs some time. So this period between the day of the infection, when the virus enters the body, and when we can detect it, it's called window period. It's like window period. Window period is the period between the initiation of infection and the time that we can detect the infection. And for IgG and IgM, the window period is between 3 to 4 weeks. For antigen, the window period is between 2 to 3 weeks. And for PCR, the window period is between almost 2 weeks. It's almost 2 weeks. So PCR has the shortest window period. And well, if that is the case, one might ask, why do we ever bother doing IgG or IgM or P24 antigen? We can always do PCR. Well, for two reasons. We also do antibody testing. First, PCR is expensive, and no, not all countries and not all diagnostic laboratories can perform PCR. So that's one reason. Antibody testing or antigen testing is are less expensive. And then the second thing is that, as you're seeing in here, RNA goes up very fast, but then it comes down. And if your PCR doesn't have sufficient sensitivity later in the course of the disease, you might not be able to detect it. So is the case for IgM and P24 antigen. That for that reason, we use a combination of these tests. PCR in the beginning and P24 antigen in the beginning, but antibodies later would help us detect the presence of immunoglobulins. All right, so that is the end of the class. Uh, do I have anything else to show you? No, I don't have a quiz question for you. So I think that's the end of the class. I enjoyed being with you, even though it was an online class, but nonetheless, it was good to have you in this class. And yes, HHV8. Yes, yes. So for Kaposi sarcoma, it's HHV8. Yes, it's also called Kaposi sarcoma herpes virus, KSHV, I think. So if you have questions, I sent you my email. I'm typing it again. This one is a Gmail address. It's because my Tom's address is usually overloaded, so it's better to send you my Gmail address, fnorbakh75@gmail.com. So you can send me your questions, and I would be happy to answer them by email. And I will also send you the slides. All right. So end of the class, and good luck with your exam. I think that this was the latest set of classes that you had. Yes, it should be over now. And I think you've done your practical classes. Some part of your practical immunology, I think, is still left. So it will be done in the next couple of weeks, I think. And yeah, I hope to see you later for your clinical immunology classes, because you would be having, if you're medical students, I think you are medical students. For dentistry and pharmacy, we don't have clinical immunology, but for medical students, uh, we also have clinical immunology 1 and 2. So which chapters are required? It depends on the book that you're reading. So if you're reading, I don't remember the number of the chapters. So if you're reading immunology for medical students, this book, look it up. I can't recall which chapters uh, where immunodeficiency is discussed. And in Abul Abbas' book, again, the summary session, if you look at the table of contents, you will find it. I can't recall the number of the chapter. Thank you very much. All right. Thank you. And see you later in your clinical immunology class. Yeah, look it up in the table of contents. I can't recall exactly which chapter it was, but if you look at the table of contents, you can easily find it. All right, thank you.